Hey, welcome to the podcast by Dr. Brown. This podcast is done on behalf of healthcare consultants, and we do wound management and protocol development for long-term care facilities. Our goal is to do skin and wound assessment, train and educate staff on managing wounds, and to have excellent outcome for the patients. So my name is Dr. Vasu Brown. My website is hollistonmd.com, and I'm a lymphedema specialist, wound care specialist, and I also specialize in using dermoscope for pathological review of wounds. And I'm partnered with Pam Cahill, who runs the Healthcare Associates consultant group, which also provides administration staff to the wound care facilities. Her website is pchealthcareassociates.com. So I'm going to go over the cheat sheet we developed for the nursing staff so they would have a better understanding of what to do. And I'm told by your staff not to go into detail why. So the goal of this presentation is to keep it very, very simple so you guys would know what exactly I mean when I ask for certain treatment. My goal is to keep it very, very simple so you understand why we do what we do. And the wound, according to national guidelines, is divided into 4 major categories: the wounds that are dry and the wounds that are wet. So there are total 4, because in the wet wound we have 3 subcategories according to the exudates: mild, moderate, and large. So of these 4 categories, we have 2 more subcategories according to the granulation, tissue versus slough. So if there is 75% granulation, 25% slough, or 75% slough and 25% granulation. This is 2 subcategories, and each of the above 4 has 2 subcategories. So like it will be dry wound with 75% granulation and dry wound with 25% slough, and dry wound with 75% slough and 20% granulation. And that would be the same thing for exudate: mild with 75-25 granulation and slough. And accordingly, we'll design the wound care protocol. So if on each week we assess the wound, the first week the goal would be to assess what else is going on in the patient and what would be the etiology of the wound. We determine whether it's a pressure or non-pressure according to the risk factors, and you go over the patient's medical documents to find out what else is going on, what could have caused the skin breakdown, whether anything systemic is going on. We assess the lab. We come up with the etiology of the wound, and then we create a skin grid based on whether it's pressure wound or not pressure wound. For all, and it doesn't matter whether it's pressure or non-pressure because the management would be the same. And if it is a dry wound with 75% granulation tissue, my first choice is I like to use MediHoney with the Wunderboot strips and a Medipore tape. The reason is the MediHoney works as an autolytic debridement, and the MediHoney, because it's hyperosmotic, wicks away the moisture from the cells, so the intracellular space is dry, so the mitochondria can breathe and can produce more cell energy, whereas the extracellular space or the on the top of the wound, surface of the wound, stays moist, since the MediHoney moist is retained on top, and the Wunderboots, because of its calamine, provides soothing to that wound edges and also wicks away the excess moisture that's happening there. And together with this moisture, it debrides that area. So we keep it simple. And the second choice, if we change the wound bed, looks like it has not much reserve, then I use zinc with dilantin as an Infitab. And depending on the wound size, if we change the wound size is big, I use 50 milligram Infitab. We found through experience that it's easy to crush the Infitab versus any other form of dilantin. And if it is a smaller wound, I use 25 milligram of Infitab, which is like a half a tab. The idea behind zinc and dilantin is dilantin works in in many, like as we know, Dilantin, when we take orally, we get gum hyperplasia. It causes swelling or tissue overgrowth to the gums. So we use the same side effect towards producing local tissue growth. And it's especially useful for some elderly who doesn't have enough reserve in the tissue to bring extra blood vessels and collagen to that area. And Dilantin supports by recruiting more blood vessels. It also works as antimicrobial. It also debrides. So there are multiple reasons for using it. But if we sense a patient bleeds a lot, then we pull back and we take away the Dilantin and rotate it and bring it back once the bleeding is better. So that would be my second choice, and it would be the same cover with Unna strips as Mediport tape. And if there is 75% slough, I would reverse the process. I'll use zinc and Dilantin first, and then I'll do the Medihoney as a second choice. And wounds with exudates, let's say it's a mild, moderate, large exudates, the choices would be similar. If there is more granulation tissue, I start with Medihoney and Unna strips with the Mediport tape. If it is more of a slough, then I prefer to start with Dilantin and zinc. But on the first week, I tend to first start off with Medihoney just to see how the tissue responds, so that it's soothing, and then I will rotate the products. And always, instead of using the same product for a prolonged period of time, I tend to rotate my products every 3 weeks so the wound base does not get used to the same products. And I keep it simple so you don't have like a lot of different products we use. And my third choice, by chance, like if it is infection, then if the patient is not allergic to sulfa, I use Silvadene. And if by chance there is lots of black areas, I use Bactroban because Bactroban kills MRSA, and also it's a little bit more gentler. So I use Bactroban to wound beds that looks infected. And I'll use the same Unna strips of Mediport tapes. If it is too macerated, then I would use a dry gauze. And if by chance it is more slough, if there are exudates, then I would use Santal to the wound bed with the Unna strips. And if there are large exudates, then I'll add with Santal polysporin powder. If by chance the wound is very, very inflamed, one of my thinking is it could be partly vasculitis, because usually the vascular inflammation causes the burning pain, which is very, very difficult for the patient. So whatever you use on the wound bed, it's going to be painful. And at that point, I'll use Zeroform. And I will apply Silvadene through Zeroform. But usually I tend to find the type of lesions also responds to Unna strips. So I try to avoid, unless it's like a very, very inflamed wound. And for all excoriations on the perianal area, I use Calmoseptine. And if there is more redness, I'll add antifungal cream or hydrocortisone cream, depending on like how the excoriation looks. Because sometimes psoriasis would appear red, but actually it could not be a fungal infection. It could be because of allergies. So then hydrocortisone works better. And for rosacea-looking skin, I use Metrogel cream. And for extremity, both upper and lower extremity, I always wrap. It's called complex decongestive therapy. It's a multi-layer wrap we use with using the cream for the wound bed covered with Unna as a strip, so there is no pressure, because when you use Unna as a strip, it creates less than 10 millimeter PSI pressure, which is almost like squirting saline into the wound bed with a syringe. And when you follow that Unna strip, which is cut in multiple layers, so when it comes around like an X strip, you cut it off, and then you apply Webril, which is also done in layers, like a strip cut off as soon as it comes around, and then a Curlex or a stretch net, which we leave it alone for 72 hours. And then I suggest you do a step in the morning and remove it at night. This is my major protocol for most of the building, and sometimes I tweak the products depending on what is going on clinically. But if you know this algorithm, I think you should do all right. So I hope you had a great time, and I'll talk to you when I see you. Bye-bye.